All right, welcome everybody to our second virtual SciEngage group meeting. My name is Jeff Hunt. I'm the Director of LabX here at the National Academy of Sciences, one of the co-organizers, along with Emily. Emily, you wanna go ahead?
Hi, I'm Emily Cloyd. I'm the director of the AAAS Center for Public Engagement with Science and Technology. And we're super excited to have you all here today on our second virtual public engagement with science group meeting. And I will introduce our host for today, Kishore Hari. Kishore, go ahead and take it away.
Hi, everyone. Thanks for being here today. I'm a longtime practitioner in science engagement. In fact, when I got started, I didn't have any of this gray in my beard. I long for those days again. But after years of working as a practitioner, I now work at the Chan Zuckerberg Initiative. One of the things that has always really excited me about the idea of public engagement in science is just the sheer number of places that we can learn from outside our normal spheres within science. So because, you know, when I sort of look at it, community engagement has been a thing that has been around as nearly as long as there have been communities. So I personally think some of the most interesting things, initiatives that have emerged in our, you know, relatively young field have come directly from people that have been willing to reach beyond the borders of traditional science to think about how to approach engagement overall. So I tried to take that theme and apply it to this month's meeting. So we've invited two researchers from the public health field to share their experiences, how they measure efficacy, key challenges, and just overall their approach to public engagement. And I want to be super clear that these researchers aren't here to tell you they've figured it all out. They've just been doing it a bit longer than all of us. I'll try as we go along to place relevant links in the chat and that are related to the work that they're discussing. I also want to remind everyone that today's webinar is being recorded and to make sure to keep yourself muted while the recording is going on. A couple other notes in terms of timeline, we'll spend a couple minutes doing some introductions and getting to know our guest researchers today, followed by, I have a series of, I don't know, about 5 or 6 questions that I'm going to ask each of them. That'll take around 30 to 40 minutes. Feel free to ask questions as we go along. The easiest way to do that is just to put them into the chat and we'll try to ask them on your behalf at relevant times in the conversation. We'll also have time at the end of the call to dive into more of your questions, which we can do by actually unmuting you so you can ask it live. With that, let's go ahead and get started. I'm going to let the researchers introduce themselves, and then we'll take a couple minutes and have them take a couple minutes to describe their research area and interest in terms of community engagement. First up is Dr. Jess Holzer. Jess, if you're unmuted, go ahead and introduce yourself.
Hi, everyone. Thank you for joining and thank you for having me. My name is Jess Holzer. I'm an assistant professor at Hofstra University on Long Island. My background in community engagement really originates with my training in bioethics and public health. And I have a PhD in health policy and bioethics specifically. And I come at it from a justice perspective. I do some community engaged research now, or community engaged work that's hopefully progressing to research, which is maybe something we'll talk about, with LICARP, which is a Long Island Community Academic Research Partnership, and then also with an organization that I'm a part of the board on. It's a nonprofit looking at active transportation, which is Long Island Transportation Alliance. So those are two very different projects that I'm working on, but both of them are focused on really generating knowledge based on community needs. So thank you.
And before we have Melody introduce herself, what's active transportation?
Yeah, so active transportation is anything that requires you to do the work to move. So that could be walking, biking, scooting. My husband is a scooterist. Anything that involves you not just relying on a car primarily to move you around. And for those of you who take trains and buses, you're active most likely because you have to walk between wherever you live and wherever the bus picks you up or wherever the train picks you up. So we sort of wrap in everyone who is using any sort of non-car transportation in that definition.
Wow. Of all the terms I thought I would learn today, scooterist was not on the
He'll be
list.
so proud.
Thank you, Jess. Melody, would you like to introduce yourself?
Hi, I'm Melody Goodman. I'm an associate professor and interim chair of the Department of Biostatistics in the College of Global Public Health at New York University. I've been doing community engaged research for over a decade. Every time I say that, I get more gray hair. My research really focuses on trying to help communities and other stakeholders build the capacity to really engage in partnerships. So we do a lot of curriculum building and training. And then my research interest is focused on evaluation and developing metrics to measure the work that we're doing.
So I want to make sure, Emily, can you hear Jess and Melody okay? Because I saw your question in the chat. Okay, well, I think we're going to move on. Melody, just really quickly, can you expand upon just a little bit upon some of the programs that you run and how long they've been going and kind of just like sort of the 10,000-foot view of them?
So we started our community engagement work on Long Island. I was a faculty member at Stony Brook University, and we started with community organizing and coalition building. And one of the things that came out of our coalition building work were community members asked to be trained on research, because they said that when they worked with academic researchers, they were always told, that's not a research question, that's not how you do research, that doesn't make sense. And so we wanted to make sure they really sort of understood the academic model and the research model and how things worked. We developed our training based on a standard Masters of Public Health curriculum, but it's for lay stakeholders. And basically, if we could take a whole MPH curriculum and make it one class, that's what it would be. So it's about 3 hours a week for 15 weeks. And we've done this once in Long Island. We've had 4 cohorts in St. Louis and trained over 125 people there. We've had 2 cohorts in Jackson, Mississippi, and 1 in Hattiesburg, Mississippi. Sorry, I was going to lose the name. And this summer, we piloted our curriculum for youth in Newark, New Jersey.
Awesome. So we're going to come back and learn a lot more about the programs and some of the results of that work in a few minutes. But I actually want to start with you, Jess. You wrote a paper a couple years ago that was essentially, here's why community engagement is important for the larger medical health sciences field. And you cited 3 different cases in it that spoke to one of the key levers here is creating much more trust and respect between the communities and the scientists. Can you speak to that? And I'll link the paper in chat.
Sure. So in that paper, I think there are 2 key themes that medical research or biomedical research more broadly is wrestling with. One is lack of participation in research trials, which means that research trials take longer. The representation in the research trial is more limited, and it just adds cost and limits the scientific relevance of the findings if you don't have the people who are in the rest of the community who might benefit from that. And that affects everything from really basic science all the way up to drug development and clinical applications. So that's one issue. And the other issue is once you have findings, nobody doing anything with those findings. The research findings that you have sort of landing with a thud and not being taken up by the communities that you ostensibly are seeking to serve. And so what we present in the paper is an argument designed for researchers to try and say, here's how community engagement can help you, but here's what you have to do to be able to achieve those ends. And it really requires this question of trust. There are plenty of historical reasons why communities in general and some specific communities, particularly communities of color or communities with economic disadvantage, would very justifiably not trust researchers. And building trust is, it's like any relationship. If you have a relationship where you have lost trust, it becomes very difficult to invest resources. And researchers are fundamentally expecting people to spend time. Sometimes it's an opportunity cost. You know, they're having to take time off of work, or they're having to put their kids in daycare so that they can come and participate in whatever you're doing. And if they don't trust you, you're not going to be able to overcome that. So these 3 examples are just some of the many, many examples out there that are designed to give a sense of how trust was built. And largely it comes down to humility on the part of the researchers, empathy, and a desire on the part of the researchers to actually give the community some voice and give them space in the conversation to have a say and to build that trust. Yeah.
So I'm going to ask a follow-up, and
Sure.
pardon the broad generalization, but in my experience, and scientists aren't always great at humility and empathy from time to time. How in these cases did the researchers like really lean into these, like, you know, kind of uncomfortable places for them? Was there training? Was there other ways that they did this? And as a follow-on to that, I would love it if you share a few details from maybe one of the cases that really
Sure.
was interesting.
So I think the Kanawake example, which is actually out of a group of Native people in Canada. So that's an example of where the research question originated and the concern originated with communities themselves. And that's really kind of the gold standard, where we as researchers don't say, oh, I got to get tenure, and I'm a diabetes researcher, so I got to find a community that's experiencing diabetes, and I got to go there, and I got to get their data, and I got to write about it, and I got to get tenure, right? That's very me focused as a researcher. In the case that's described in greater depth in the paper, this was actually a community that identified that they had very high rates of diabetes, and they were very concerned about obesity among their children, which is heavily related to later stage development of diabetes. And so they said, we should seek some researchers. And by reaching out, they had a lot of power in that relationship as a result, because they were setting the rules. They were establishing, we would like this question answered. We would like to work with you. And if the researchers themselves had been perhaps overly pushy or had decided they wanted to take it in a different direction, it's an opportunity for the community to say, look, like, this is not what we're into. And that balance, that the community understanding that they have some power in the relationship, and the researchers understanding that the community has that power as well, I think that's a key way in which researchers can start to change. And now I can't speak to each of these cases because I don't know them personally. I know them from reading the literature. So I don't know if the researchers came at this as just more empathetic and more humble people in general, or if they received training. It is true that in medical research and biomedical research, humility and empathy are not part of what you're trained to do. And that's one of the reasons why I wrote that paper, is because I was trying to encourage people who are already in the field, who are past their major training steps, to think about that as an area where they could develop. That's a skill set that they could still start to develop. And there are trainings available. Certainly cultural competency is trying to get to that. And you know, the sort of flip side of what Melody's going to talk about, of training community members to a researcher model, is also trying to train researchers to a community model, teaching them where the limits of their knowledge actually are, because that's not something they're often taught in their training.
I want to poke at one thing that that you kind of lightly touched upon and also brought up in our pre-chat, which is that a lot of what you see here, a lot of the currency that's being offered is a fundamental shift in sort of power dynamics between these two groups, which, you know, in a way is more about justice than it is about science. Can you talk about those two concepts melding together and why you see power and ceding control as being so important here? Yeah.
So, I mean, if you think about how a lot of science does its work, we create a lot of gateways and barriers to becoming a professional. So I think this is true about academics, but also true about people in a lot of professional fields. You have to go through a ton of training. You have to prove yourself in a lot of different ways. And so if someone hasn't gone through that, they rank a little bit lower, right? And we're encouraged to think about that hierarchy and ending up at the top, and that's where the power concentrates. Like a CEO doesn't get to the position of being a CEO unless they've made it through a lot of different levels, right? And that has worked for a long time, but it's been very limited. And so one of the things that I personally think is really necessary in research, and this is just for research to be successful, right? This is not just for community engagement. This is not specific to like this small subset. This is in order for research to be successful, Oops, sorry about that. Understanding who actually has the power to make it successful requires that stepping back from a confidence that you have that power, and instead thinking who else in this room or even in this community might have that power. And it's going to require a shift, because traditional academia and traditional hierarchical organizations are not built like that. Typically, you have a sense of who's in and who's out, right? Who has the moniker in their email address that is, associated with the company, or who has it associated with the university. And that gives you access to things. It gives you access to library resources. It gives you access to human resources and other things. And in order for you to reach out into the community, if you're not doing it right now, continuing to do what you're doing is not going to get you out into the community, right? You have to think about, what do I not know? What do I even not know I don't know? And who can I speak to about that? And that's where that power shift comes in, is acknowledging that you don't know what you need to know to answer a problem. And therefore taking on the perspective of, okay, I have to ask someone. I have to be humble enough to acknowledge that a question needs to be asked, and there's an expert out there who can answer it for me.
That's awesome. Engagement isn't a tactic. It's a process that's embedded in research to make it better. Mm-hmm. I'm going to transition over to Melody, and you have a different model here, one that, as Jess mentioned, you're bringing the community in and having them learn about a research-based model. Can you take us through a little bit more about that model and some of the work you've done and what you've seen in terms of the community members? And I want you to start with like a question. I'm sort of like shocked that members of the community are interested in like diving in headlong that way.
They love it. They come early, they stay late, they want more. So I agree that training needs to happen on both sides. And I think people are shocked that I'm doing the community side, but I actually found that it's easier to train the community members on how to do research with academics than to train the academics on how to do researchers with community members.
Oh, mainly this group knows that problem well.
So I just felt the community was really open to it. It's a program that you have to apply for. So they put in applications, they commit to this sort of semester-long process. And we find that they're deeply engaged in the process. I'm a statistician, so I make them do lots of evaluation metrics, and they do all of them with a smile on their faces. And they're really sort of engaged in this process. And then what we've seen work afterwards is we offer small pilot grants for them to develop their own projects and find a researcher to work with. And lots of times the researchers we have them work with, so we're sort of unofficially training researchers because we have them come in and teach the sessions. So they don't know that they're learning. They think they're teaching. But by putting them in a classroom with a bunch of community members and having them ask questions, and for the first time having instructors not be able to get through their slides because the students interrupt them so much, unlike when they teach academic classes and they can sort of do death by PowerPoint. These community members are going to go, I don't understand that. I need you to re-explain that in a way that sort of makes sense. Can you relate this to my current health issue that I'm having? So it really makes them think differently. And so we're sort of secretly training the academics by having them teach in our program for the researchers. And we bring in a different person each week. So they're exposed to different researchers working on different problems. It's all been in public health because that's my area of research. But we bring someone who does social determinants of health. We bring in someone who does health disparities. We even bring in our medical library to tell them what resources are available to the public. We've brought in the public libraries in both Suffolk County and in St. Louis. We bring in a medical librarian who can talk about literature searches and how do you find things on Google and trusted sites and et cetera. And we find that there's people who are affiliated with community-based organizations, of course, and faith-based organizations and social service workers. But most of our people are just community members that have no organizational affiliation. And we find that people who've lived around a university often want to know more about research because they've been asked to participate in it, but maybe they have or haven't for whatever reason. So they know that this thing exists. And I think most people in the public want to help, but as Jessica mentioned earlier, especially in minority communities, which are the ones that I tend to work in, and medically underserved and low socioeconomic status, there's been some historical things that we as researchers and public health practitioners have done wrong. And rightfully so, they should be afraid of us because we've messed up a whole lot. And those are only the ones that we've been public about messing up a whole lot on. There's lots of messing up in private that no one really talks about. And so I think people want to help science, but they don't want to be hurt. And I think that makes sense for anyone. And so they really are interested in figuring it out. And the other thing I would say is, when community members can say things like study design or recruitment and how you're going to do, like when they just use our language, researchers tend to treat them differently. So just by having them learn a few key words, when they come to the table, they're not looked at as this odd community alien, right? They're looked at as someone who sort of understands what's going on. And it really helps them help us, because lots of times I've seen community members at the table and they have no idea about the conversation we're having. They're just sort of sitting there rubber stamping whatever we're asking them to do. But when they could say, hey, wait, maybe this isn't the right population for your intervention. Maybe you should go to this social service agency, and maybe you should talk to this person. I mean, they could really change the way we sort of do things and be really instrumental if they understand what we're trying to do. And so really, we're just trying to help them understand what it is we're trying to do. We're trying to help them understand the academic model. What is tenure? Why do people come in my community and want data and leave, right? So we help them understand these things so they can just ask the right questions. We're trying to make informed consumers of research. So a lot of my work is about what I call increasing research literacy and just having people understand what research really means and how it works.
So I have a lot of follow-ons, so I'm going to try to do and break them up a little bit, so it kind of makes sense. This is a takeoff of a question that Elise asked in chat. So when you're doing capacity building in Long Island, and then you go to St. Louis, those are totally different communities. And then when you go to Hattiesburg, Mississippi, how are you applying this program work, which at the core I'm assuming has like some of the same components, but have that extend to new cities and sites, but do it in a way that is relevant to those communities, which are going to be fundamentally different?
So I'm from Queens, New York. And I went to Stony Brook as an undergrad. So Long Island wasn't that strange to me. I was sort of a member of that community for a long time, and they were really accepting. When I moved to St. Louis, I was an outsider. So it really made me feel like what community members feel like when they come to academic circles. As soon as I opened my mouth, people knew I was not from St. Louis. And so right away, they could identify me as, this person doesn't belong here. And just having that feeling made me able to really relate to how community members must feel at the table when they have something to contribute, but they don't say it in the exact language that we're used to hearing, how we probably all stare at them and make them feel like they're weird beings when they're really sort of helping us. So I think the work has been effective in both places because, and in Mississippi, mainly because everywhere we've been, it's been affiliated with a university. So that university was already there. There were already researchers there doing research. There were already people there trying to do engagement. So these communities weren't strangers to research. They weren't strangers to people asking them to partner in things, but many of them had just said no, mainly because either they had had bad previous experiences or they really just felt like, I don't know enough to bring to the table. And so we're really trying to educate them that, like, no one knows what it's like to live in North St. Louis more than you, right? I may have this PhD from Harvard and I know a lot about the social determinants of health, but I have no idea what the day-to-day life is like in North St. Louis. So you have something to bring to this table that I don't currently have. And you know, the way communities work, there's always like formal structures and informal structures, right? And researchers tend to go to the formal structures. But in many minority and medically underserved communities, the way to get things done is to find those informal structures. Who is Ms. Johnson that everyone knows and everyone trusts, right? Who is nurse such and such that everyone wants to take their kids to? And if you don't get out into those communities and find those key people, then you're going to take a long time recruiting, because once these people bless you, then it changes. It's like game changing in terms of what it can do to help you in your research. So I think these communities are interested, and I think we as academics didn't look at them in that way. We thought they would never want to learn this stuff, but they do. It's their life, especially when we bring public health out. It's sanitation, it's food, it's transportation, it's their day-to-day life. These are decisions that we're asking people to make when they choose politicians and other government officials. And so giving them some education is really important. And you're probably gonna slide into this a little bit, so I'll only touch on it. But as medicine turns into precision or personalized medicine, really having some research literacy is going to be key in order for you to just have regular conversations with your doctor for treatments and the like. And so I think there's people out there that really want this information. They want to come to a place they trust. So even though oftentimes they don't like XYZ academic center, they do trust that this is a place to get great schooling and education. So they trust us in our training. And then it allows them to build relationships with the actual faculty members, to see them other than just professors, as people who live in their community, who are working in their communities on key issues, who care about the community in the way they do.
So I think most of us on the call have been at events or run events where there is this power dynamic that Jess was alluding to before, where there's a researcher at a podium talking at a crowd oftentimes, and that power dynamic makes it hard for those people in the audience to pipe up and to ask their question and to really engage, because it's intimidating, it's uncomfortable, it's a new space. How do you look at empowering these communities to ask questions, especially when it's sensitive questions related to health, of these figures that appear as authority figures?
So when we first did the program in Long Island, we took it off campus. We actually put it in community libraries. So we tried to put it in their space, and we made the academics come to them. And so I think that changed the dynamic a bit. The other thing I would say is most of our participants are African American and Hispanic, and we try to make sure that our faculty mirrors the participants. So we bring in lots of minority faculty as well, so that they're seeing people that look like them, that have these degrees from great places, and they formally adopt half of these kids. You know, Dr. Such and Such is my son that went to Hopkins. You know, like they really are proud of these people working in their communities. And so I think that's one thing. When we moved to St. Louis, something interesting happened. We were going to put it in the community, but we actually decided to put it on our medical school campus because the community members felt like that was a space that wasn't welcoming to them. And so we wanted them to see that they were welcome on our campus, that the training that we offer wasn't just for these elite student populations, that the university sits right in their community, should be a tool and a resource for them. A lot of them didn't know that we had public access to our medical library during certain hours and certain times. So we really tried to open up our campus in a new way that made them feel welcome. And the interesting thing really happened. We found that we would see community members in our lounges and our lobbies, spaces, and our meeting spaces having meetings. They really sort of took to the campus after that as a place where they could hold meetings and they could get together. And so I think it works both ways. I think you really have to be selective in your faculty. So I select all my faculty by hand. And when the program was implemented in Mississippi, the person who led the program there did the same thing. And this is one of those cases where, like, the dean asked me if she could teach in my program, and I told her no, because I didn't think that she was appropriate. And it's not about all your great education. It's about, can you take your knowledge and talk to someone in a regular way, talk about real things and real problems. Some of us do research that's really abstract, right? So, you know, can you talk about it in a way that it impacts their day-to-day lives? And I don't really care about all the alphabets you have behind your name. I'm really looking for people that are interested in community work, are interested in working as community partners, working with community partners, and really co-learning with community members and being able to share the results and share the outcomes equally. And our dean just had too much power to be in that space. And so I'm really conscious of those things.
I'm smiling because that's a conversation we've been having internally amongst this group as well. Like, who's the best suited for this? Do we need all scientists to participate in this, or is it the right scientists, or is it some mix thereof? So thanks for diving in there. I'm going to transition to a different topic. Martina asked a question, and this is for both Melody and Jess. Do we have practical, successful frameworks for building trust that we know has worked in public health? Or is this still very experimental?
I think we definitely have some lessons learned, but there's no evidence-based framework for how to build trust. I think Jess said this earlier. It's like any other relationship. You know, you have to build trust the same way you would build it with a coworker, your boss, your significant other, the man at the grocery store, whatever. And so the reason why I'm particular about the people I pick is that I want to pick people that treat people well. And we know not all academic researchers do, and can really understand that In this research game, there's no room for hierarchy. If you really want good outcomes, then everyone has to have an equal place at the table, and feel free to speak.
So I just want to echo what Melody said, which is that you build trust in relationships with the community the way you build trust in relationships, right? So it's both a difficult question to answer and one of the easiest questions to answer, because it's something that we've been trained for since birth. We build relationships with other people. So I think Melody makes a great point, which is that there are no evidence-based protocols that one can use. And one of the reasons for that is that, like, to Melody's point, and Kishore, you brought this up, Long Island and St. Louis are going to be different places. They have different experiences. There are different just people there, right? Like, communities are not just sort of monoliths. They're composed of people. They have politics within them. There are relationships within people there, right? If you're talking to one person and that person's mortal enemy is who you need data from, you're gonna, like, that might be a challenge that you walk into not aware of. So I think the other thing is to try not to get too attached to, I'll take this example over here and I'll just apply it over here, because you have to be willing to be flexible. You have to be willing to do the back and forth and have a conversation. So I think maybe it moves a little bit away from a framework. There are some frameworks that can help you in terms of your thought process. So it's not so much like a checklist framework of a step-by-step thing you have to do, but it's more like a thought process. So Barbara Israel and Nina Wallerstein and Meredith Minkler are three people who have written a lot about community-based participatory research very specifically. And that's not just within the public health sphere. Public health is heavily represented, but you also have anthropology, sociology, psychology and mental health. Lots of other places can use that. And I think it has application across a wide variety of sciences if you're looking at going to the community. That's a place to start in terms of thought processes and orientation, because they very much specify, like, CBPR is not a research methodology, it's an orientation to generating information. It's sort of in the line of, like, qualitative versus quantitative, sort of what counts as information and how do you evaluate it. And I think I don't want to turn this into just a golden rule conversation, but one of the key lessons is, if you sorry, I just saw the comment about the citations, thanks to somebody else who's writing it up there. There are several things, there's not just one thing to cite. They have written a couple of books on it. But think about yourself in a relationship. Think about the times that you have felt like trust has been broken. Like, what did somebody do to break your trust? Did they make a promise that they didn't follow through on, right? Did they tell your information to somebody you didn't want them to? Did they take something from you that you hadn't given them permission to do, right? These are really basic sort of interactive things that we have done to people. All of us can probably name a person in our lives who has done one of these things to us, and we no longer trust them. We won't hang out with them. We won't give them our access to our personal information. We won't talk to them, those sorts of things. So too with research, right? If you go, or not just research, but so too working with communities. If you're a professional who goes to a community and you tell them, oh, we're going to get you this big, awesome thing, and we're going to solve this problem, and this is going to be great. And then you take their data and you walk away, and it could be because you lost funding or your boss doesn't support what you're doing or whatever. All they've experienced is that you promised big and you delivered small, and they're not going to trust you the next time you come in. And so I think that's really, it's very basic, but also very complex. And it really just requires us as professionals, researchers and others, to take responsibility and treat the members of the community with whom we're working as seriously as we would treat our dean or our boss, in terms of somebody to whom we owe when we promise something.
So you brought up the words qualitative and quantitative. So you know what's coming next. How the heck do we measure any of this, especially when it comes to stuff like trust and humility? Engagement is, at least personally for me, has been a really thorny thing to measure in a way that speaks to the scientific research community. So can you talk to how both of you have done this? Because both of you have spoken to this issue in some of your publications.
You want me to go first? So there's a systematic review that was just released by Dr. Deb Bowen that actually looks at stakeholder measurements of stakeholder engagement. What we found a lot is that most of the work has been qualitative in trying to measure how people are engaged, etc. But and that's great, but then it's hard to compare one project to another or different projects at points in time. And so there's a new push to develop more quantitative measures that could also be used in larger studies and be used in larger samples. And so there's some measures out there. There's a Community Engagement and Research Index and a few others. NIH funded a bunch of projects not too long ago to look at measurements of community engagement. I actually currently have a PCORI funded project that's looking to validate a measure that we're creating. So I think there's a dearth in the literature, but there's a bunch of people right now working to try to create measures now. So probably in a year or two, we'll have too many measures and we'll be figuring out which ones are the best.
Anything you want to add, Jess?
Sorry, I was looking for links. So I think Melody is definitely the expert in this domain. I think one of the ways of evaluating is if your goal is to, say, have more people participate, and more people are participating, to some degree, that is a process measure that you can say, okay, some of this was beneficial. And it doesn't necessarily have to be a super complex process, not to take away from what Melody is doing and how she's working to standardize it. And obviously, as a biostatistician, she has some serious thoughts on and how well we measure. But I think there are also some fairly basic measures that you can implement without a lot of investment, which is if we're not meeting our targets, start asking people what's going on, right? You know, if you have somebody that you've been working with in the community and they're, say you're trying to improve participation, you want more diverse participation in your thing, and you've reached out to somebody about that, and you're not seeing that diversity change. You speak to that person and you say, so I'm not seeing diversity change. I'm just, I'm looking at the population who's coming and it's just the same old people. And they say, well, you've scheduled it at a weird time. You schedule it midday because it's convenient for you. And, these people that you're trying to get, they have full-time jobs. They can't take time off. And that becomes, those are sort of mini measures, ways of on the fly doing some formative evaluation of what's going on that can help you to get a sense of it. And so I'm on the editorial board of a journal called Progress in Community Health Partnerships. And PCHP is its shorthand. And one of the things we have, one of the most frequently submitted to sections is lessons learned. And you can see how people have tried to put in formative evaluation and tried to talk about where their lessons are. And what would be awesome, I don't have the time to do it, Melody, I don't know if you do, would be sort of a systematic review of what the lessons have been learned across all of these publications. It's been published for over 10 years. We've had lessons learned submissions. So there would be a really interesting way of trying to consolidate just practically what have been lessons that people have learned, what has failed and what has succeeded. And that might be a place to start for a more standardized evaluation strategy.
And we'll try to post links to some of the things that were just mentioned in the coming minutes. I have two more questions before we turn it over to the crowd. One is that I guess, I mean, this is something I've personally struggled with, is public engagement with science and the way we talk about it as our community is relatively new, at least in the US. And one of the things I think we're struggling with is how do we demonstrate this approach, this mindset to the larger field, to like all of those deans and heads of museums and whoever who really can see that we're generating value. How has that conversation gone about demonstrating value of engagement models within public health?
I think schools of public health are starting to get it, but we're not all the way there yet. It doesn't count probably the way it should for promotion and tenure. I remember when I was first starting, I was told as a junior researcher, not to do community engaged research. Obviously, I don't listen to what people tell me because I did it anyway. We've been warned that, it'll take you longer to get tenure, or you may not get it. I think I'm in a different place because I'm a biostatistician, so I'm less likely to get fired if I'm doing random things, as long as I calculate people's power and sample size correctly. No one's going to scream too much. But I do think we are starting to think about how to count these things. I do think journals like Progress in Community Health Partnerships, where some of our work has been published, are really good because it lets people publish on lessons learned and things that are maybe don't have empirical data yet. There's also another journal called CES for Health, which takes non-journal-like, so other products that are not journal articles that may come out of community engagement. So I think the public health people are really trying to figure out ways how we get people credit for the work they're doing. I think we're doing better than other fields, but not good, if that's that's the nicest way that I can say that. But I do think that there's a large cohort of people in public health that are doing community engaged work and really thinking about it. And just to get on my measurement soapbox, I think this is why measurement is so important. I think people know that community engagement works. There's lots of stuff in the literature that says it works, but no one knows how it works. How much of it do you have to do? Who do you have to do it with? When do you need to do it? How long do you need to do it for? And I feel like if we don't measure it, we're never going to figure out those questions. Like, it's nice to have lessons learned, but it's better to have evidence-based practice. And so I think it's important for us as a field, and I think this is where public health is going, is that we start measuring it so that we could start developing evidence-based practices that then we can then disseminate to other fields.
That's awesome. Jess, do you have anything to add to that?
Yeah, so I think Melody makes a great point that one of the things that public health is starting to do, and part of it is that this is coming from the edges, and it's coming from people who have been a little bit brave. They were told not to do a thing, like Melody is saying, and then they did it anyways because they couldn't imagine pursuing a career without doing that. It just didn't feel right in a lot of cases. So that's some stuff. And a lot of those people have started to see if the power and if the structures for advancement and the people in power don't see it, how can we translate it into what they see? So if they need to see publications, okay, fine, we write it, we develop a journal that addresses that. If they need to see it turn into grants, okay, fine. And that, in some sense, that's actually been nice because you have PCORI, which is the Patient-Centered Outcomes Research Institute, and one of its key tenets is community engagement, patient engagement explicitly, because they recognize that a lot of what's failing in medicine today is that the people who need the medicine the most are not involved in the research studies and they're not involved in decision making, and so we build programs that don't address their needs, right? That, we do a lot of our diabetes research on people who only have diabetes, but most of the people in the community who have diabetes have other comorbidities, right? They're not involved in the research because it makes for messy science if you've got kidney failure or if you've got other type, major obesity issues, heart disease, et cetera. But then on the, in the practical side and the clinical side, if I'm a doctor, I have somebody who has all those things and I don't know how to treat them best. I just haven't been equipped with the science to do that. So all that to say that there are now structures that are coming into place. Patient-Centered Outcomes Research Institute, the National Institutes of Health, which does the majority of funding for health research, also had the CTSA program, the Clinical and Translational Science Award program, which was designed to try to get them moving. Like Melody said, we're not doing great, we're doing better, and we're doing better than we were in the past. We can still do even better, but I think strategically thinking about that. And then the other thing is that, from my perspective, I teach in a very different institution than Melody does. I am free to not have to get grants in order to supply my salary, which is a really big deal. And that gives me the freedom to explore stuff that is a little less grant funded and, or is a lot less grant funded, is totally ungrant funded. So that I think has given me a power that might not be available to everybody else. And I think just mentorship among researchers. If you're interested in it, speak to people who are doing it, who are a little bit higher than you are, and find out how are they doing it. Are they feeling successful? Are they getting pushback? And you just keep finding people who say yes. You're going to meet a lot of people who say no, but if you keep finding people who say yes, there are enough out there that you can get the support you need.
I have a million more questions, but I realize I have the power, so I'm just going to limit myself to one more. And that's, where are you drawing inspiration from? Because as I said at the top, and as you've mentioned, like, you haven't figured it all out either. So where are you learning from when it comes to engagement from outside the field of public health?
I think when you work with community partners, you get lots of unofficial inspiration. Particularly this program I ran with youth this summer. I always say the best outcomes of any community engaged study are the ones you don't anticipate. We trained 12 African American middle and high school girls on research methods, and at the end they created a video themselves. They came up with their qualitative research questions and they interviewed each other about their experiences in the program. I probably should have thought of that as the researcher, which I did not think about, but they did. And now I have this thing that's on YouTube and will last forever about how much they learned and how much they enjoyed the program. And so for me, that like filled my heart up, and I wasn't going to do it in the fall, but now I'll probably do it again in the fall. I will say to everyone that engaging community members is hard work. You will be very tired, but I think the rewards make it worth it. And I'm the kind of person that if I had to come to work every day and do the same thing, I'd be bored. And so you'll definitely never be bored if you do community engaged work. It's always something fun and exciting and interesting and challenging.
So similarly, I draw a lot of inspiration from the community members that I work with, because so one of the community members, Jacob Dixon, who is the CEO of Choice for All, which is in Roosevelt, New York, he's just unflagging. Like, he just never runs out of energy. And I don't know how the man survives. So when I go home and I'm like, oh man, I have to publish or something like that, I keep in mind that, you know, I get to step away from stuff. I get to put it down in a way that the people who are living with these things, be it communities that are beset with severe diseases or that are struggling with economic, failing to have economic independence, and they're struggling with poverty or crime or any of these other things, like, that just is their way of life. And you have to appreciate the amount of energy it takes to just keep going and keep pushing against those challenges. So I think that's really inspirational. And I also draw inspiration from other researchers. The nice thing about being on the board for Progress in Community Health Partnerships is that I get to read other people's work on a regular basis. And I get to see, I'm like, oh, wow, that's so interesting. And each of those people is not, they're addressing a relatively small space, right? They're working with a community in, Northwest Washington, and it's not affecting anything in, where I live, but they're still doing really interesting work. And I think that's very inspirational. Just seeing other people struggling with it, it's basically a virtual group therapy session. So it's really powerful.
With that, I'm going to turn it over to all of you. If you have a question, Jeff and Emily can unmute you and you can ask your question directly. And while people are sort of formulating their thoughts, there's one more question in the chat that just emerged from Mark, and which is really about, like, we're talking about communities in this sort of like very idealistic way, that they all have good intentions, but as we know, some communities do have bad actors within them. How do you manage that experience, especially given historical examples?
So we try not to have any bad actors at our table. And that's the nice thing about doing community engaged research. There's a bunch of people in the room, so you don't always have to be the one to tell them they're not welcome. Sometimes someone else is happy to tell them they're not welcome, or just make them reasonably uncomfortable enough that they don't want to come back. I think when you're doing this type of work, it's hard for the bad actors to just sit in there, because the community can, like a snake salesman or something, they will point you out in a minute and they will let you have it. And so it's not really a space for people who don't come with good intentions. And the work is so long and so hard that if you're not there for the right reasons, you're probably not going to stay at the table for long. I mean, I wasn't doing research in the 1960s when the tobacco industry is at the table, but I will say, obviously, we made them pay. That's why they have to give all this money to public health now. So when they sit at the table, we will make you pay, I guess, is the answer in public health.
Fair enough. Are there other questions out there? Jeff, Emily, do you have anyone that wants to unmute? think, Martina, do you have a question?
Yeah, I actually do. So I'm relatively new to this, or, I direct my attention to community-based research and initiatives. Are there examples of communities that were connected as a result of some initiatives, perhaps locally, within states, across states? So when you mentioned Washington, I can imagine situations where communities can learn from each other, even though they are on the surface in a very different context, but may have underlying similar challenges.
So there's actually several organizations. One is Community Campus Partnerships for Health. And then another one is, I think, NC Bon, and I don't really know what it stands for, but I know it's like a group of nonprofit organizations. So there's sort of, particularly affiliated with the American Public Health Association, there's already some sort of community circles where community members have a space. In APHA, there's also the Community-Based Public Health Caucus, which is actually a mix of academic researchers, public health practitioners, and community people and organizations and the like that sort of work in a space together. So there are some like national organizations. Community Campus Partnership for Health, I think, is the biggest one that I know about, that really help the community partners link to one another with some great success. They even have an annual conference, I believe.
Awesome. Sorry, go ahead, Jess.
Yeah, just to add to that. So what Melody is talking about is creating spaces also for community members to talk to each other, which, she pointed to a number of different national structures that allow that. So depending on, I know not everyone on this call is thinking about health in particular as a public health person, and so APHA might not be appropriate, but depending on what your professional organization is, you could determine, is there a community-oriented group there? Or is there space made for community members to be participants? And if not, can you help to institute that? Oftentimes I find that people are just waiting for somebody to self-nominate. It's not that they don't want to do it, it's just that they don't want to do it, right? I think that if that's something that you don't see existing, it might be something worth creating. Give yourself some time to do it, and it does take work, and it requires, usually it requires finding one person in the broader community who's like, yeah, that's interesting, and then it sort of spitballs a little bit from there.
All right, I think we have time for 2 more questions. So there's one in the chat, and then Jemima has a question. Jemima, do you want to go first? Let's see if we can get her unmuted.
You have a question or no?
No, Jemima doesn't have a question. Okay, if not, I'm going to ask the one in the chat. What about navigating faith-based perspectives and I think the interesting quirk here is so a lot of us deal with science that isn't health focused. It can go into more of that basic realm. So how do we navigate some certain community perspectives, especially faith-based perspectives, when we start to talk about genetics and genomics and just basic research in general?
So I actually think public health has done a pretty good job in this space. We have a whole sort of field of people who study health communications. I've done some work myself in the genomics space, trying to figure out what patients want when we return findings from whole genome sequencing. So we just recently completed an R01 about patients' communication preferences, what they want to know, when they want to know it, particularly among women who were diagnosed with breast cancer at a young age, where having some information can impact treatment and the like. But then we may have other information about things that affect their kids or their family members, and having that information at the time you're diagnosed may not be super helpful. And so we really have been asking patients what they want to know. I think we have to take a step back. One of the things that we looked at when we were writing our grant is that all the sort of guidelines about releasing genetic findings came from the professional organizations, and not that those are the right people to be making those things, but it seemed like they hadn't ever considered the patient's perspective and what people would want. And so I think we just have to think about how we would want to be treated, right? When you would want to know things, who would you want to tell you? Probably someone who has lots of expertise in whatever they're talking about. And in terms of the faith-based issue, so St. Louis is a very religious place, and that's the nicest way I can say that. One of the things we found is just to be open and honest. Here's the question, here's the potentially ethical issue, here's what some people are saying about it, here's what other people are saying about it, here's a space for you to make your own choice. And really just giving people sort of the full gamut of what we know in science, and also what the major sort of ethical debates may or may not be among scientists and others.
We have time for one more. Does anyone out there have one question? If not, I have one question to wrap up with.
Could I jump in and just add a little bit of a
of course
on the last question? So I think another thing before you start figuring out sort of how to approach the faith-based community, I think you should ask yourself, what is your goal in understanding how to work with a faith-based community? Are you looking to understand perspectives, or are you looking to try and shift perspectives? Because I think there can be two goals. One can be like, I just like to understand what your limitations are and how I provide a structure to if you don't want to hear about one thing, or you don't even want some options made available to you because they're just a violation of your religion, and you would like to just have that conversation before anything else is discussed. But then there's the other, which is trying to convince people to do a thing because it's technologically or medically recommended, even if it is culturally or religiously prohibited. So I think asking yourself, which of these are you trying to do? Because then that's going to shift your strategy. So in one case, you might just start with asking a question, right? Like, how would you like this to be done? Exactly what Melody said. If in the other case, you're trying to push and you're trying to shift, that may be one of those moments where bringing a little bit of humility into it becomes relevant, right? Some people may never participate in what you want to do because it is anathema to them. And that is a population that you're just going to have to get comfortable with. So depending on where that question is coming from and sort of what the goal is, I think might structure what you do. If you just accept that a population might never support what you're doing, might never want to be a participant, or if you're trying to sort of come to an understanding with somebody who at least has some basic willingness to work with you. I think that's going to structure it a little bit. Sorry, that just came up.
So just because we're running out of time, I'm going to actually wrap us there. You can keep the conversation going on the Trellis link that's posted in the chat, and we'll try to post relevant links to the research that was discussed today. I want to thank both of our guests today, Melody and Jess, for taking their time to talk to our community. So thank you so much. And Emily and Jeff, is there anything you want to say to wrap up?
Nothing on my end, except we'll be doing this again in September, on September 21st, and we'll be talking a little bit about one of the themes that we had today, which was engagement with underserved communities. And then we'll have another one in October. But if you have ideas for future topics, or if you want to be like Kishore and be the ringleader and then be the one who recruits the people who talk, please let me or Emily know. And if people aren't on Trellis, go bug Emily, and she will get you access to that. It's a great place to have these discussions continued in addition to having these virtual meetings.
Thank you, everyone, again. Thank you again, Jess and Melody, especially for reminding us just to get out there and do it, because there are a lot of rewards when you do. So thanks, everyone, for joining us, and see you next month.
Thanks, everyone.